Hello and welcome to the Piper Pearl on conducting a pain assessment. Pain is a highly complex process that unfortunately most clinicians don't really understand. So the goal of today's Pearl is to have a closer look at a general pain assessment and really focus on how our questioning techniques and gathering of subjective data can assist us in targeting objective findings in order to better help our patients. So when we look at pain as an overview, I've already mentioned that it's quite complex. People will often say that it's very subjective. It's a mixture of physical versus emotional means, but we'll try to get a little bit more technical than that, and we'll look at the processes of pain. So you're right, acute pain, which is what we're talking about today, is a physiological response, and it's designed to warn the body of danger. Now, the process is all about nociception. That means interpretation and detection by nociceptors, neural fibers. Now, generally speaking, there are four basic processes involved in this nociception, or the perception of pain, if you will. They are transduction, transmission, perception, and modulation. When we look at the transduction of pain, we are looking right at the base where the nociceptors are formed. Now, there's two primary types of nociceptors. You have C fibers, which are associated with more of a slow, unmyelinated response. And then you have your A delta fibers, which are designed to have your fast response, so very fast conduction because they're myelinated. Now, the transduction phase is all about the detection of chemicals and inflammatory properties like your bradykines, prostaglandins that are leaking from damaged cells in the area. Now, these nociceptors will pick it up and they will basically interpret it and create an action potential. Now, the presence of noxious stimulus, chemical, thermal, or mechanical stimulus, is what causes the cells to break down initially. And with that cell breakdown is where we get the actual release of these chemicals that can be detected before it moves on to the next phase, which is obviously your transmission. Now, transmission is broken up into three phases. So it's actually the transmission of the neural impulse from the nociceptors to the dorsal horn of the spinal cord, and then from the spinal cord to the brainstem itself, and then within the brain, through the brain, connecting the thalamus, the cortex, and the higher levels of the brain. Now, once it gets to the spinal cord region, we start relying heavily on neurotransmitters that often excite at this stage. So during the transmission side of the house, it's dealing with the excitatory phase of it. So adenosine, glutamate, things like that will play a very big role in this transmission of pain itself. So when we look at the brain closer, we need to be aware that the brain doesn't actually have a discrete section within it that is designed for detecting pain. It's a mixture of a number of areas, and that's where we move into the next phase, which is that perception of pain. So perception is what we interpret as the feelings of pain, and it's the end result of all the neural activity of that pain stimulus that has been passed through. And it is multi-dimensional experience, as is mentioned. So if you look at the picture on the right, that's more got to do with the perception of pain. So the multi-dimensional aspects is the actual affective, so the motivational ones. You've got your sensory, you've got the emotional, and you've got your behavioral components. Now, these areas and these feelings are assisted by or activated by different regions of the brain. So we have the reticular system, which is responsible for the autonomic and motor response to pain and the warning of the individual that that something bad is going to happen. Then we have our somatosensory cortex, and that's involved in the perception and the interpretation of that sensation. So it identifies the intensity, how many signals are coming through, how large the region is, all that sort of stuff. And then we have our limbic system, which plays a very strong role in our emotional and behavioral response. And this is where our personality, our experience of pain, our situations, all those things come into it with how we physically portray these feelings of pain themselves. Once that feeling of pain has been felt and basically portrayed through emotions and behaviors, then we have something known as the modulation of pain. Now, the modulation of pain is where that connection between acute and chronic comes into play. So it involves the changing or the inhibition of those transmissions of pain impulses. So as we've mentioned a few times in the past, we have our own pain analgesic neurotransmitters within our own body, and it's the opioid receptors that are responsible for that euphoric feeling. So the modulation of pain can involve the activation of that, or it can actually involve the excitatory aspect of this pain, which makes it amplify and a lot more complex pain at this state. When we go through the assessment, we'll draw on a bit of this knowledge that we just talked about in the pain overview in order to get a better understanding of how our questioning techniques can really assist our patient. So the mnemonic that we're going to use is the classic PQRST. Starting with P stands for provocation and palliation. So that is simply asking the patient what activities relieve the pain and what things aggravate the pain. So if you're dealing with musculoskeletal injuries, generally using the muscle makes it a lot worse and resting the muscle doesn't. When you're dealing with deeper, your organ type pain, your visceral pain, then you'll find that people getting in certain positions, putting pressure on it, bending over, will actually relieve the pain as opposed to aggravating it. So it's just a matter of quantifying what makes it worse and what makes it better. When we move on to Q, which stands for quality and quantity, this is where our descriptors come in. And this is where our interpretation of those C fibers and delta fibers can really come into play. So a C fiber, as I mentioned, is slow. That's mostly associated with your visceral type pain, the ones that are connecting to your receptors associated with your more chemical, thermal, and mechanical, but it's sort of lower level threshold. So think of it this way, C fibers are often associated with your tummy pains. You get that low, dull, diffused pain in your stomach when you're bloated, and that is all associated with those C fibers. You're not really jumping around the room carrying on. Okay? It's often associated with your parasympathetic, even though it's not quite, but it's a parasympathetic response because you don't want to kill something. You don't want to jump up and fight and dance around the room when C fibers are activated. And generally speaking, when you have your alpha fibers, people will describe those as sharp, stinging, prickling sort of pain, and they're associated with your high threshold mechanoreceptors responses. So only when the threshold becomes great will delta fibers actually be activated and be denoted as a sharp, stinging pain. And that is best described as standing on a Lego block. You jump back like it's a massive attack on your body. All your vital signs change and you want to kill that Lego block. It's the instant response you have, and that is your delta fiber response. So someone explaining the pain generally tell us what sort of thing we're dealing with. Again, musculoskeletal pain that's acute is mostly sharp, whereas your visceral pain is generally those slow fiber ones. When we move down to region and radiation, this is where things get quite interesting. So there's a lot of theories associated with why referred pain works, and they've done a lot of effort trying to map where it comes from. But the leading theories are mostly associated with where the organs start during development. For example, the diaphragm starts in your shoulder during development, and then it moves down and there's a connecting nerve. But the leading theory associated with it is where the surface sensory neurons and the visceral neurons meet at the dorsal horn at the spinal cord. So what I mean is let's just say we have the classic heart pain that is felt, during ischemic cardiac arrest. You feel it in the neck and down the left arm. So when we look at dermatones on that area, neurons that are connected at the same level on the spinal cord, because your body's not used to feeling your organ. So you're not used to feeling your kidney, you don't really know what your heart feels like. So when a sensation comes from one of these organs, generally speaking, the message gets sent to the brain. But that message is often interpreted as a surface message because that's normal. You generally feel the dermatome response as opposed to an organ response, which is why your brain interprets it as a problem or a pain sensation associated with that aspect of the skin. So when we go through specific pathophysiology, we'll have a closer look at certain disorders that give you this referred pain, but that's where the referred pain actually comes from, and that's where the term radiation of the pain can come into play. The other aspects of radiation is you can either have pinpoint pain or you can have that diffuse pain, which is ill-defined. Pinpoint is generally associated with a tear of a particular area that you can, in fact, pinpoint. You get the patient to point with one finger, and they can generally denote it that you will find later during observation, or they will be unable to do that, and there's just this general diffused feeling across it, and that denotes that we're not actually dealing with necessarily an injury, we're probably dealing with some sort of visceral stimulation from there. When we move down to S, this is where people often do the simple thing, which is not helpful at all, as opposed to really exploring that pain. So severity really tells us what we need to do about this pain and what sort of thing we need to do. So when we score the pain on a scale of 1 to 10, to me, that's the most useless question you could ever ask because it is too subjective. Even if you say, oh, what's the worst pain you've ever had so I can have a reference, you don't have a reference. You have no idea what the worst pain they've had. Even if you've had the same, it's probably completely different to yourself. So scale from 1 to 10, sure, do it because people like to see it written on there. Sounds great during a handover, but it's really useless. If someone's in your clinic or talking to you in the field and they come and they go, oh yeah, I've got 10 out of 10 pain, but there's no physical response to that, 10 out of 10 pain means that nothing else exists in their life except for this pain. They cannot interpret your questions. They cannot think about anything else. Pain is their life. And if you're doing a PQRST assessment on 10 out of 10 pain, then you've really failed as a clinician. You should have treated them in the emergency state. So scale, do it, don't pay much attention to it, move on from there. The big questions to do with severity is we've got to wonder, like, how much do we need to intervene with this pain? So how does it interfere with their activities? Are they unable to sleep? Do they not feel like eating? Are they no longer exercising or walking? So how does it affect their life? And does it force them to act a certain way? Again, go back to the tummy ache. Most people want to curl up in a ball, hold themselves tight, and just lie in bed. That is forcing them to do something. Can ask some questions about episodes, but don't confuse it with the T, which is the timing. Episodic pain means that is the severity increased during certain activities? So you can quantify the pain associated with certain activities, gives us an understanding of what sort of mechanical response is happening that we can more pinpoint a pain to. Now, if the person's taken pain relief before, let's say they've taken non-stop Panadol for the last 2 days, and they've come in on the 3rd day with the pain, and you prescribe them Panadol. It's like, okay, not really going to help. So ask what pain relief, what techniques they've done already, what sort of relief they've got from that. So we're really trying to quantify how bad this pain is, because remember, not every pain needs analgesia. Analgesia is designed for short-term use, just to help people get over a certain aspect of acute pain. The final question we look at is our timing. So we ask when it started. That's not the only thing we ask. Okay, asking when it started is great, so we can generally get an idea of if we're still in that inflammatory stage, if we've moved to proliferation phase, and generally what's happening in the body. But we can also ask, is how often is this pain occurring? Is it a constant pain, non-stop, 24 hours a day pain? Or does it only happen at certain times during the day? Is it worse at night? Is it worse during activity? That sort of thing. And with that timing, is there any other accompanying symptoms associated with that pain? So you may in fact have a stomach ache, but do you have associated diarrhea? Do you have vomiting? Do you have a fever? All those other things that link the subjective data with the objective data that we'll move into. So once we get a good PQRST assessment, we'll generally have an idea of what we're dealing with. Okay, the idea is to narrow down on what sort of pain we're dealing with, how bad it is to help us with our plan, but also to denote certain characteristics of the pain description that are indicative to certain pathophysiological responses. And that's where our objective component comes in. So we always do vital signs. Now, if you have those classic acute A delta fiber pain, there is a strong correlation with that pain and an increased heart rate, an increased blood pressure, increased rest rate, and a decreased SpO2. Okay, so there's the vital signs you can have associated with those changes. But then you can also look at the person's behavioral change. You can't put a huge amount of weight on it, okay, but you can look for facial expression changes. You can look for outward displays of pain, that sort of thing. But outward displays of pain don't necessarily mean greater pain than small changes in facial expression. Okay, there's a lot of personality, stoicism that goes into it. So we need to really grain of salt that one, but we need to look at the way they are acting, because the way they're acting can give us an indication of how much it is affecting their life, their mood, all that other stuff. Look at the way they're sitting, look at the way they're standing, look at if they're guarding certain areas, look at their shape, their posture, in order to denote whether or not the pain is causing or forcing their body to be in a certain position to alleviate that pain. And then, of course, we do our physical findings. So you look at the area they're describing, you look at the associated referred areas, and you have a good palpation, inspection, all that sort of things to help really back up what we're thinking based on the subjective data that we've just collected. Okay, so that's it for our pain assessment. As I mentioned, there's a lot to go through with a pain assessment, and this is more of an overview that we'll dive into with certain disorders that have characteristics of pain that you can get from our subjective findings. But until next time, take care.